Okay, wonderful. Shall we start?
Sounds good.
Okay. Good afternoon. Thank you to the Young Nephrologist Committee in AFRON for organizing this educational webinar. And thank you to Letitia and Theola for their administrative help. I'm Zabia Bade. I'm a nephrologist based in Cape Town in South Africa, and I'm a consultant at Groote Hospital, which is affiliated with the University of Cape Town. So this exciting webinar is going to take place in two sections. The first section is going to involve three interesting electrolyte presentations by Dr. Thabit Jardine, and this will be followed by insights and short talks by Professor Davids. And then the second section will take some questions. I'd just like to introduce our guest speakers. So it's an honor to introduce Dr. Jardine, who's currently a fellow in nephrology at Tygerberg Hospital, which is affiliated with Stellenbosch University in Cape Town. And I first met David on a STATA course, for which I will be forever impressed on how gifted he is in stats. And his academic interests are centered around access to kidney replacement therapy in South Africa, as well as electrolyte and acid-base disorders, and he's passionate about medical education. It's also a great honor to introduce Professor Rosine Davids. He is head of the Division of Nephrology at Stellenbosch University and based at Tygerberg Hospital in Cape Town. And he reminded me before this talk that he's been there for over 36 years, which is a great legacy. And he's incredibly knowledgeable and has taught me on a few occasions and highly respected throughout South Africa. And Professor Davids was a ISET fellow in nephrology back in the day and had the opportunity to study electrolyte and acid-base balances disorders with Professor Halperin at the University of Toronto in Canada. He also has other interests which include medical education and epidemiology, the epidemiology of chronic kidney disease. And Professor Davids is an ISN educational ambassador and a host mentor to many ISN fellows, which come from quite a few African countries, as well as from Nepal. He's also involved in establishing the South African Renal Registry, as well as the African Renal Registry, and he is deputy editor of the African Journal of Nephrology. And with that, I'd like to hand over to Dr. Jardine and Professor Davids.
Thank you very much, Sophia, for the introduction and for the kind invitation, and also to Afran and the administrative team behind the scenes. It's a pleasure to be involved. Thabit, over to you.
Thank you, Prof. Let me share my slides. Okay, so I suppose it's appropriate to say good evening, everyone, but plausibly it may still be good afternoon to some of you. Thank you for the lovely introduction, Zabia. I feel really privileged for this opportunity. Together with Professor Davids, we'll be tackling some case-based teaching around some salt and water disorders, particularly hyponatremia. So I will be presenting some contrasting short cases, while Prof. Davids will lead the teaching around the cases. We'd love for this to be an interactive session. And so for those who are able to, very shortly, you'll see a QR code on your screen. We're going to ask that you use your cell phone camera rather, to scan in this QR code. And this will give you access to several MCQs throughout the course of this presentation. So for those of you able to, just pull out your cell phone, scan in the QR code, and please do not hesitate to submit your answers because they will be anonymized. So we'll allow half a minute or so to allow time for everyone to scan in this QR code.
Thanks, David. This is really exciting.
Awesome. Another 10 seconds or so, and then we'll proceed. All right, we'll move on to our first case. Case 1 is a case of hyponatremia following laparoscopic surgery. So the patient is a 34-year-old female. She weighs 60 kilograms, and she's been struggling with infertility due to submucosal fibroids. otherwise previously well. And so she undergoes an elective laparoscopic fibroidectomy. Intraoperatively, the lavage fluid used during the laparoscopy is 10% dextrose water. So that's got a concentration of about 505 millimoles of glucose per liter water. And otherwise, she receives 2 liters of normal saline intra-op. So pretty routine anesthetic stuff. You are consulted post-operatively. You are informed that the patient developed a ventricular tachycardia with hypotension, with blood pressures of 80/40 at the time. While you were en route to the recovery area, the anesthetist successfully cardioverted the patient. And by the time you arrive, the patient is normotensive, back in sinus rhythm, and sitting up, generally actually looking quite well. So some bloods are taken at the time, and there are a few striking results. There's a plasma sodium concentration of 90 millimoles per liter, and a plasma glucose concentration of 100 millimoles per liter. Importantly, the potassium at the time is 4.2, but there are no other mention-worthy abnormalities. So given this very low plasma sodium concentration of 90 millimoles per liter and this very high plasma glucose of 100 millimoles per liter, you are faced with 3 treatment options as per the calling anesthetist. And he says, should we give some hypertonic saline? Should we give some isotonic saline? And should we give insulin? Now, at this point in time, if you scan the QR code, you should see an MCQ pop up on your phone. We're going to ask everybody to vote. And remember, it's absolutely anonymous. We'll allow about 20 seconds or so. Looks like some folks are still voting. Maybe some change of votes over there as well. Okay. So we see that about a third of the audience thinks that we should give hypertonic saline. 2/3 think no. We'll move on to the next question. Would you give isotonic saline? Okay, similar proportions by the looks of it. Okay. Just allow a few more seconds, perhaps. Looks like most people have made up their mind. All right, we'll move on to the next slide then. And the final question is, would you administer insulin? Okay. Thank you very much, everyone. So some years ago, the very same case was sent to a group of experts comprising endocrinologists, ICU physicians, and nephrologists. And as you can see, you are in relatively good company with nearly half of nephrologists opting for hypertonic saline. And as you can see, the majority thought that the patient should get isotonic saline as well. Similarly, most nephrologists, or not most, but about split down the middle in terms of insulin. About half thought that insulin should be given, and about half thought that it shouldn't be given. Okay, so thank you very much for your votes. And I'll now hand over to Prof. Davids to do some teaching around the case.
Thank you, Thabit. So I'm going to run through some background physiology, which is useful to keep in mind when you deal with sodium and water disorders. And the first thing we'll discuss is how the body controls osmolality, and that is how, in fact, it controls cell volume. The body wants cells to be a certain size. They work most efficiently when they're not too big, not too small, and the control is via osmolality. So body fluid compartments, if you go back a bit, body fluid compartments depend on your body mass. So 50% of your mass is water if you're a female, and 60% if you're a male. So for example, if you were a 60 kilogram female, as in our case, you'd have 30 liters of total body water. 2/3 of this would be intracellular and 1/3 extracellular. And if we look at the osmolality of body fluids and these compartments, osmolality is the same throughout the body, inside and outside cells, but the particle to water ratio, osmolality is simply the particle to water ratio, but the particles on the inside of cells would be mainly potassium, and outside cells it would be sodium and the anions that go along with it, so chloride and bicarbonate. On the next slide, you see how we might calculate osmolality from the usual lab test that we do all the time. And we simply add up the commonly measured particles in a liter of ECF. So you might take the sodium concentration plus chloride and bicarbonate, or you might simply say sodium times 2 to account for the anions that go along with sodium. If you want to be a bit more accurate, you might add potassium and calcium to that formula. And then we add glucose and urea, and we get an osmolality of close to 300 milliosmoles per kilogram water. So that's how we normally calculate it. What the lab does when we send them a sample for measuring osmolality is they look at the depression of the freezing point. And that is the method they use. And I always show these two slides from my wonderful one-year sabbatical and fellowship, ISN fellowship with Prof. Michel Prin in Canada. On the left was the house where we stayed, and on the right are my children tobogganing down a hill. And as you see there's lots of snow all over the place. And on those steps you see in the picture on the left, I slipped and fell down those steps twice in my time in Toronto, because what happens is that after a period of light snowing, overnight the snow freezes into a thin layer of ice on those steps. And if you're rushing out the door, first thing in the morning, late for work, wanting to catch the subway, you slip on that ice, and I flew down those stairs on more than one occasion. When I told this to my colleagues at the lab, they were puzzled and asked me, don't you put salt down on the steps? And I'd never heard of this before. Of course, I'd never been in a country where there was snow and ice. And it turns out that adding salt or putting salt down on the street or salt down on the steps causes the freezing point to drop. In other words, the snow does not become ice when salt is put down. And that's how the lab measures your sample. The higher the osmolality, or the more particles in that solution, the lower the freezing point. In other words, if water freezes at 0, a sample with osmoles inside would be freezing at a temperature below 0. And from this, they can deduce the osmolality. Next slide, please. So when we think about water moving into and out of cells in patients who become hyper and hyponatremic, the two driving forces are really osmolality and hydrostatic force. Above, you see osmolar force pulling water to the right-hand side. And at the bottom, you see hydrostatic pressure pushing water across. Now, osmotic force is by far the more powerful force. A 1 milliosmolar difference across a cell membrane would exert a sucking force equal to 19 millimeters of mercury. So by the time we see the patient and we measure osmolality, water has already moved, right? By the time you see the patient, cells have already swollen or shrunken, so that the particle to water ratio is equal. In other words, we've reached osmotic equilibrium. We can therefore say that the osmolality determines cell volume, and because sodium is the major osmole, we can say that sodium concentration tells us about cell volume. On the next slide, I just show you a picture of the brain to emphasize the fact that we are not too worried whether a muscle or a liver cell shrinks or swells a bit. But our concern is the brain and brain cells, because when the brain swells in the rigid cranium, intracranial pressure goes up, and we risk herniation of the brain with serious or even fatal consequences. So here you see a cell in a patient with a sodium concentration of 126 millimoles per liter. In other words, 10% lower than normal. And that cell has now gained water and is swollen by 10%. The next cartoon illustrates that it does not matter whether this hyponatremia comes about as a result of sodium loss or as a result of water gain. The effect on the cell in terms of its swelling is the same in both cases. We have to decide whether the hyponatremia is from salt loss or water gain by clinical assessment, right? Looking at things like the history of fluid intake, losses, vomiting, diarrhea, and then examining the patient, looking at things like the JVP and edema and so forth. That's how we decide about ECA volume and therefore sodium content. On the next slide, we simply show that hypo and hypernatremia should make you think or focus on thirst, water, and ADH. It's more of a water problem in most cases than a salt problem when we deal with hyper or hyponatremia. So the osmostat in the hypothalamic area will sense by swelling or by shrinking. It senses the osmolality and then either releases ADH or inhibits the release of ADH, or augments thirst or suppresses thirst, depending on what the patient needs. And that brings us to the next principle, and for this I'll hand over to Thabit.
Thank you. So the physiology principle number 2 is that glucose is an effective osmol in plasma only when transport is a rate-limiting step. So although it seems intuitive that because all cells require energy to function, glucose should easily be able to cross cell membranes, the rate of glucose transport across cell membranes is not the same in all tissues. For example, glucose diffuses rapidly in and out of hepatocytes, whereas glucose transport is a slow step in skeletal muscle and across the blood-brain barrier. So if transport across the cell membrane is limited, then glucose acts as an effective osmol. It stands to reason that if the rate of glucose transport across the cell membrane is limited, then glucose may indeed drive an osmotic shift of water towards it. So this is particularly true when ECF concentration of glucose is much higher outside of cells compared to inside of cells. And in situations where there is a lack of insulin or lack of insulin action, for example, in DKA. And when a bottleneck in glucose transport arises due to slower flux of glucose across cell membranes in certain tissues, like the brain when compared to the liver. So then back to the case. Plasma osmolality is calculated by 2 times sodium plus glucose plus urea, but since we know that urea is not an effective osmol, we can establish that effective plasma osmolality can be calculated by 2 times sodium plus glucose. And when we do the calculation in this particular case, we see that the effective osmolality is 280 milliosmoles per kilogram of water. We ask again, would you now administer hypertonic saline? Because quite clearly we can see that despite the very real and severe acute hyponatremia, ultimately it's plasma osmolality that determines whether water moves in and out of cells. And in this particular case, with a normal plasma osmolality, brain cells are not swollen, and so there is no need for hypertonic saline. I'll hand over back to you, Prof.
Yeah, so that was option 1 of the quiz you answered. Option 2 was whether or not you'd use hypertonics or isotonic or normal saline to expand the ECF volume and support the blood pressure. Well, the question is there really ECF volume contraction? The patient was well to start with. This was an elective surgical procedure. And then we hear that she received 2 liters of isotonic saline during the course of the surgery. We also think that she absorbed glucose water via the lavage while they were doing the laparoscopic surgery. So if anything, her ECF was expanded with additional saline and glucose water, and certainly no isotonic saline was required. The third question we asked was, in the face of that very high glucose concentration of 100 millimoles per liter, would you administer insulin? So one of the dangers of giving insulin, as you'll all be aware, is the fact that in this two-step process, it will result of the shift of potassium into cells and may cause hypokalemia. And therefore, one should be careful before just jumping in and giving a patient like this lots of insulin. The main way that the body in this case is going to reduce that glucose concentration is by glucose clearance by the kidney. The patient has got absolutely normal GFR, and if we think of the GFR as being approximately 6 liters per hour, then at 100 millimoles per liter, that's the glucose concentration, we'd be filtering about 600 millimoles of glucose per hour. And if you consider that the renal threshold, the proximal tubule will reabsorb 10 millimoles per liter, that means we'll be excreting over 500 millimoles per liter, millimoles of glucose in the hour. In other words, absolutely no need for insulin. So no need for hypertonic saline, no need for isotonic saline, no need for insulin in this interesting and unusual case. All you need to do, and the team involved, is to relax and wait for the kidney to restore everything back to normal. Thanks, Taufik. Let's go on to case number 2.
Thanks, Prof. We'll move on to case number 2 then. So case number 2 is about hyponatremia at a rave party. The patient is a 19-year-old female. She weighs 60 kilograms, previously well, loves a good party, and collapses on the dance floor, is brought to the emergency center very confused. These are her plasma and urine chemistries. Please take a moment to analyze the results. Although we have highlighted the very obviously low plasma sodium concentration of 120 millimoles. So I'll just give the audience a couple of seconds just to digest that. So then we're going to move on to the first question. What is the likely cause of her hyponatremia? And you can use your cell phones to vote as you did before. We'll give it maybe another 20 seconds or so. All right, I think we'll move on then to the next question, which is, how would you manage the hyponatremia? Okay, we'll give that another 10 seconds or so, and then we'll move on. Okay, thank you for voting. Looks like the majority voted for giving hypertonic saline. And I'll now hand over to Prof to do some teaching around the case.
Yeah, so most of the cases that you'll see of acute hyponatremia, in other words, hyponatremia which develops within 48 hours, will be hospitalized patients who receive hypotonic fluids. When you see a patient with acute hyponatremia coming in from outside of the hospital, it's going to be one of these categories. You'll see it in marathon and ultramarathon runners, long races, where people are spending lots of time on the road and drinking lots of water. You'll see it in patients with psychogenic polydipsia. You may encounter the odd case of beer potomania, and then, as in this particular case, in association with the use of the drug ecstasy. So we saw quite a few cases like these when I was in Toronto around about 2000. There were cases in Canada, in the UK, and elsewhere of young ladies who would be brought to the emergency units after rave parties with seizures or confusion and have severe acute hyponatremia with brain cell swelling. And there were several fatalities. So what we think is happening is that these young people were advised that water would protect them against some of the other side effects of ecstasy. So there was this preemptive water consumption even before the rave party started. They would then have this party in a warehouse in a very hot environment, and they'd be drinking water all the time. Not always because they were thirsty, but because they were told that it would be protective. We think that ecstasy reduces your aversion to drinking water as you become hyponatremic, right? So normal people will simply not be able to drink as much water as these young people drank. We did a little experiment in the lab when I was there, and we decided to drink a water load, which is 20 moles per kilogram. So if you weigh 80 Ks, that's 1.6 liters. You've got to drink over half an hour, and it's extremely difficult. Towards the end, you become quite nauseous and you can't stand the sight of water. So ecstasy, we think, took away this normal aversion to continued water drinking. Also stimulates ADH release via the mechanism you see on the screen, and also directly. And then because of decreased GI motility, you may have water collecting in the gut, and after presentation, the plasma sodium may fall even further once this water gets reabsorbed. So when you get a patient like this, it's acute symptomatic hyponatremia. You have to treat it aggressively. You've got to raise the plasma sodium concentration and suck water out of these swollen brain cells. And a nice, easy rule of thumb, simple to remember, is that you can raise plasma sodium by 1 millimole per liter by giving 1 millimole of sodium per liter of total body water. So in our patient, who was a 60 kilogram, a young female, total body water was therefore 30 liters, 50% of her mass, and we would need 30 millimoles of sodium to raise the sodium by 1. If we decided that our target was 5, we'd need 150 millimoles of sodium to raise the plasma sodium by 5. Now, if you have, for example, 3% saline available to you, which most of us would have, the concentration of 3% saline is around about 500 millimoles per liter. In other words, half a millimole of sodium per mil of the solution. You therefore need 300 milliliters of that solution to give your patient 150 millimoles of sodium. So that's what you need to do over a few hours. One of the experts in the area, Richard Stearns, recommends that you give slow boluses of 50 to 100 milliliters of hypertonic saline, which can be given through a large vein. It doesn't need to be a central line. And he gives this every hour to give the total dose that you plan to give in the first few hours, aiming to correct or raise the plasma sodium by about 4 to 6 millimoles in about 4 to 6 hours. And just that small, apparently small, rise in the sodium concentration is usually enough to pull enough water out of the brain and improve the symptoms dramatically. So the messages from this case is when you've got acute hyponatremia, you've got to fix it rapidly. You cannot go with saline and isotonic saline or simply with water restriction. You've got to use hypertonic saline to move water out of those swollen brain cells. Remember that there may still be water in the GIT that can be reabsorbed, and that therefore sodium may fall even further after presentation. And a final word is that prevention is important. People need to know the side effects of ecstasy and the deleterious effects of excessive water drinking. Over to you, Thabit.
Thanks, Prof. That takes us to our third and final case. This is a case of severe hyponatremia in a 78-year-old lady that has been feeling unwell for 3 months with postural hypotension clinically, and she's got a plasma sodium concentration of 112 millimoles per liter. We'll move on to a quiz. What do we know for sure? Is this acute hyponatremia or is this chronic hyponatremia? I'll ask you to vote once again. I'll give that another 10 seconds or so. Is there anybody else that would like to vote? Okay. Looks like the majority of the audience agrees that this is chronic hyponatremia. So then we move on to the next question, which is, what is the expected and appropriate renal response to the patient's ECF contraction? Should urine osmolality be very low with ADH being switched off, or should urine sodium be very low? Okay, I'll give it a few more seconds and then we'll move on. Excellent. I think it's time to move on to the next slide then. Okay, so in hyponatremia, as Prof has said, cells are swollen regardless of how the hyponatremia came about. And one of the important questions to ask is how the hyponatremia did come about. You know, was it due to the numerator or sodium decreasing, or total sodium or salt loss, or was it due to water gain? And as Prof mentioned previously, this is really clinically determined. And regardless of what the cause was, the cells are swollen in hyponatremia. So in this case, we agree that there seems to be ECF contraction and probably salt loss here. And that definitely contributed to her developing hyponatremia. We make the point that in chronic hyponatremia, the brain protects itself by exporting osmoles, limiting the osmotic shift of water into brain cells. What are these osmoles? As Prof mentioned earlier, potassium is really the most abundant intracellular cation, and so that's really most of what the brain exports. And this adaptation takes about 48 hours or so. And that's why in a patient with chronic hyponatremia, the acute danger to the patient is called the doctor, who too aggressively corrects that hyponatremia. Because the problem is that it takes time for the brain to re-import those exported osmoles, especially when there may be, for example, whole body potassium depletion, as in the case of individuals with alcohol use disorder or malnutrition. And this de-adaptation can take 5 days. And I'll now hand over to Prof to do some teaching around the case.
A little bit about the control of ECF volume. And that is really, the body does this by controlling sodium content. If you consider that the major osmol in the ECF compartment is sodium, and that is what holds the water there, then at a given sodium concentration, the more sodium you have means that the bigger the volume of that compartment. And the body will therefore respond to ECF volume changes by focusing on the sodium intake and output. So if you were hypovolemic, let's say after a week of diarrhea, for example, with a contracted ECF volume, you'd be activating the RAS system and the sympathetic hormonal system. And aldosterone would cause you to reabsorb sodium avidly. Now, if you look at the sites in the nephron where sodium is reabsorbed, the bulk is reabsorbed proximally, 80% in the proximal tubule, but the fine tuning and what determines what we actually excrete per day, that happens in the cortical collecting duct right at the end. And if we zoom in there, we see that sodium chloride comes along, and then under the influence of aldosterone, which has opened the sodium channels, ENaC, the epithelial sodium channels, sodium is reabsorbed either together with chloride, because we always need electroneutrality, so a negative and a positive reabsorbed, or as you see below, sodium is reabsorbed and potassium is excreted. So when we deal with hyponatremia, we always ask whether it's acute or chronic, and the time course is important, 48 hours or longer than 48 hours. Is the patient symptomatic? And is this likely to be due to the hyponatremia? And then, as David said, do we think this has come about mainly as a result of sodium loss or mostly water gain, as in the ecstasy case we discussed earlier? This algorithm says the same thing. Yeah, in this case of ours, we've got a duration of less than 48 hours. So we're going down the right-hand side to chronic hyponatremia. They're very mild symptoms. The patient does not have seizures or coma. So we go down the left. And our job, therefore, is to treat, find the cause for why ADH is activated and remove or treat this cause, and then to slowly correct the hyponatremia. The next slide just emphasizes the differences between acute and chronic hyponatremia, which should really be thought of as almost two completely different diseases, right? The time course is different. The causes are different. In acute hyponatremia, like in the ecstasy case or in the marathon runners, it's really water overload. Whereas on the right-hand side, in chronic hyponatremia, it's often sodium loss plus or minus water gain. And the key there is that ADH has been present for a long time, preventing the patient from excreting water and normalizing the sodium concentration. And the common causes are firstly hypovolemia, which is not inappropriate. It's often a physiological response to hypovolemia, but then things like drugs, nervous system, or lung disease. The dangers to the patient are different. Brain swelling, as we saw in the patient with ecstasy, and then in the chronic hyponatremia, the doctor causing osmotic demyelination by too rapidly correcting the hyponatremia. And then again, the treatment, aggressive on the one hand and very careful on the other when we have chronic hyponatremia. Our target should be less, our ceiling should be less than 8 millimoles per liter per day. So if we look at the case, in the light of the ECF contraction, we would have wanted to see the kidney hold on to sodium. In this case, the patient had a high urinary sodium concentration. This is renal salt wasting and made us suspect something like Addison's disease, right? When we zoom into the kidney, the potential causes for sodium wasting, or let's say the mechanisms, would be lack of aldosterone action to open up the ENaC channel, an inhibitor sitting in the channel, something like amiloride or trimethoprim, or just a kidney which is not working. In this case, we considered Addison's disease, and this was later confirmed when we got our plasma aldosterone levels back. It was virtually undetectable. While we were waiting for those lab results to come back, we gave a trial of synthetic fludrocortisone, and this caused urine sodium to disappear and urine potassium to increase, which really confirmed the diagnosis. So to summarize this case, Addison's disease, lack of aldosterone causing inappropriate urinary sodium loss. Combining this with a poor dietary salt intake led to the patient developing a very contracted ECF volume, which was a stimulus for ADH to be around and maintain the water gain and hyponatremia. And to end off, Thabit, I'm going to hand over to you.
Thank you, Prof. Last question, I believe, is so let's say the patient's plasma sodium rose from 112 to 122 millimoles per liter on day 1 of admission. The question is there a significant risk of developing an osmotic demyelination syndrome? We'll just give the audience about 20 seconds to vote there. Okay, most unanimously, the audience voted that the risk is high. Okay, we'll move on then. So, as we've emphasized, when dealing with chronic hyponatremia, one can really risk stratify with regards to the risk of developing osmotic demyelination. The risk is obviously higher in those with more severe hyponatremia, under 120 millimoles per liter. And most importantly, slow correction is advised, aiming for 4 to 5 millimoles per liter per day. We mention a ceiling of 8 millimoles per liter per day. This is not a target, this is the maximum. And in fact, even something lower than 4 to 5 millimoles per liter per day in the setting of an improving patient is acceptable. And we emphasize that in those with additional risk factors, such as those with hypokalemia and alcohol use disorder or malnutrition, one should be even more cautious and aim for the lower end of correction. If overcorrection does occur, one can use DDAVP and or dextrose water to limit the rate of rise in plasma sodium concentration. And that's all we have to say. Thank you very much.
Thank you, David and Razine. Those are wonderful cases that you presented, and it explored nicely the complexities that we sometimes have with sodium and water abnormalities. I just want to check if there are any questions that anybody has. I don't see anything in the chat at the moment, but maybe I can ask something. Razine, one of the common questions that I get asked is the influence of temperature on osmolarity, especially when you do the measurements and take the samples. Could you maybe comment on that?
Yeah, there's a lovely paper by one of our fellow nephrologists, Carla Bezuidenhout. I don't know if you know Carla. She was until recently based in the Northern Cape. She's just moved to Worcester. Yeah. And when she was a registrar in internal medicine with us, we did an MMed project together on the stability of samples of blood and urine for measurement of osmolality. Because we were finding that at Tygerberg Hospital, 1/3 of our samples were being rejected by the lab because they hadn't come to them on ice. They had these rules about sending us, we had to get the sample, I think, within 4 hours, or if it was longer than 4, it had to get to them on ice. And otherwise, according to them, the measurement of osmolality would be unreliable. So we decided to dig into this, ask them for their references, dig into the references of those references, and we found no basis for this. I won't go into the detail, but we then did a formal osmolality stability study where we took samples and we assayed them up to, I think it was 24 hours. I'm not sure if it went longer. If Carla's online, yes, you should chip in. And to cut a long story short, these samples are as stable as 24 hours is fine if samples are left at room temperature. Blood and certainly urine. And because of that, the protocols at our lab were changed. I'm not sure if it's permeated to other NHLS labs across the country yet, though.
No, that's very useful. Thank you. And I just wanted to look at some of the questions in the chat. Mazar has said, thank you to both of you for the wonderful talks. He wanted to know if you have any thoughts on the use of tolvaptan in patients who have hyponatremia.
So because we don't have it available, it's really been a non-issue for us, Zabir. But one would always be worried about, about uncontrolled, not having a controlled and slow rise in sodium. The one thing I didn't go to in detail here, which maybe if we've got a minute or two, I can just mention. You see, often you're not quite sure what caused the ADH to be present. Sometimes it's obvious. There's hypovolemia. You fix that up. Sometimes it's a thiazide-diuretic. You stop the diuretic. And then you need to be on the lookout for ADH then being turned off and a large water diuresis. And you've got to be ready then to put on the brakes to slow this down by using DDAVP plus or minus dextrose water. So that's quite a tricky thing to do, especially if you don't have good monitoring and nursing of, and somebody to check the output. So what some people like Stearns have recommended is using what he calls a DDAVP or vasopressin clamp. In other words, he would use DDAVP from the start. From the time he takes away that ADH stimulus, he stops the diuretic, or he fixes the contracted ECF volume. He'd use DDAVP to prevent a large and uncontrolled water diuresis and a too rapid rise in plasma sodium. So he'd give DDAVP and then allow it to wear off for a few hours, allow a little bit of a diuresis, and then give more DDAVP just to slow it down again. So it's quite a tricky thing. If people are interested, they can look at his Stearns paper in AJKD, Richard Stearns. And that's probably what you should do if you don't have good monitoring of urine output, to pick up the start of a big diuresis.
Thank you. Another question from Professor Chothia. So Yazid asks, if one overshoots correction of the sodium during chronic hyponatremia, will time use reduction in the concentration avert the risks of ODS?
Tavi, do you want to tackle that?
I can unmute. Yes, Prof, it is my understanding that using DDAVP can certainly reduce the risk of developing osmotic demyelination.
So what this implies is that we are able to check sodium quite frequently and get results back quite quickly during the course of a day, especially in that first day or two when we start treating a patient with severe hyponatremia. So let's say we get to the 12-hour mark and we've overshot. We've corrected by 10 or 12, where we want to limit it to 8 or less. At that point, then we could step in, as Tavi suggests. And all the evidence is that if you then bring the sodium back so that at the end of 24 hours, you're within that ceiling of 8 millimoles per liter, you prevent osmotic demyelination. Might not be an absolute. I mean, there are the odd case where demyelination has happened with smaller degrees of correction, but for most cases, you will spare the patient the risk of osmotic demyelination if you do that.
Thank you. And then just a follow-up question by Yazid is, if hypokalemia is present, he is asking, should you first correct the potassium before correcting the sodium during in the context of chronic hyponatremia?
So I think the key there is to remember that if we, let's say it's often in a patient maybe who is malnourished or ECF contracted, and we tend to want to give normal or 0.9% saline, and then we piggyback or add a few ampules of potassium chloride. This transforms isotonic saline now into hypertonic saline, and we just need to be aware of that. So we may have to, while we're fixing the potassium, we may have to use half normal saline plus KCl, so as not to overshoot on correcting the plasma sodium concentration.
Okay. And Walter Malloy from Botswana is asking the hyponatremia in the first case, was it pseudo-hyponatremia? And then a follow-up question with, is the hyponatremia in the setting of hyperglycemia benign?
Tabi, do you want to try that?
Yeah.
Or
Sure. I can speak to that one. So the hyponatremia in the first case was not pseudo hyponatremia. That was indeed a real hyponatremia. It was a dilutional hyponatremia, which is not the same as pseudo hyponatremia, which usually comes about from abnormally high lipid or protein levels, and that's a slightly different concept, which interferes, has implications for the ways in which we measure sodium. But if one uses a direct ion selective sort of method for measuring the sodium, then one is not sort of hindered by the pseudo hyponatremia problem. But yeah, it's a separate issue. This is a dilutional hyponatremia and not pseudo hyponatremia.
Thank you, Thabit. And Thabit, another question that arose was from one of the participants. How do you treat hyponatremia or approach hyponatremia? How do you approach chronic hyponatremia in a patient with chronic heart failure who has edema?
Sure. So we spoke about the stimuli for ADH release, and we spoke about one of the appropriate stimuli from a survival perspective is ECF contraction, and perhaps more accurately, decreased effective arterial blood volume as well. So that could stimulate certainly ADH release in the setting of heart failure. And so the key is really to improve perfusion, as I understand in those cases, right? So yeah, that's my understanding of hyponatremia in the setting of people with heart failure.
it's a difficult one. It's a difficult one if you can't fix the heart.
Exactly.
And it's a prognostic factor. Hyponatremia with heart failure is a bad sign, telling you how bad the heart failure is.
Yeah.
So it's a delicate balancing act between giving a little bit of diuretics without decreasing the effective renal perfusion too much, and it can be quite tough, quite a tricky one to handle.
Thank you. And then just one of the last questions from Mazar from Tanzania. Wanted to know if you could shed light on the categories that sometimes are used in hyponatremia when they categorize it according to volume status, with hypovolemia, euvolemia, and I think he means fluid overloaded, being hypervolemic. Could you shed light on how that fits in? Because it wasn't in one of the algorithms.
Yeah, so I think when we ask ourselves, how did this come about? Is this largely because hyponatremia is simply a low sodium to water ratio? So is it largely sort of a low sodium problem, or mainly too much water, as in the water drinking group of acute hyponatremias we dealt with first? And once again, as we said before, that's really up to your clinical assessment. Old-fashioned traditional history taking and clinical examination, and then you decide if the patient's total body sodium is likely to be normal, decreased, or increased.
Thank you. And sorry, one last question by Yazid. What about the use of urea for chronic hyponatremia?
Yeah, so this was made popular, at least as far as I'm concerned, as I know, by two Frenchmen called Decaux and Soupart. And they had a patient with, I think, with lung cancer. No, it couldn't have been lung cancer. Some sort of malignancy with ectopic production of ADH and hyponatremia. So in other words, the cause was not easily removable. And they had to then manage this chronic hyponatremia. And they decided to use oral ingestion of urea as an osmol, which would force additional water excretion, causing the hyponatremia to return towards normal, but mainly to allow the patient to at least have a little bit more flexibility with the intake of water on a daily basis. So they did, I think they had a patient they wrote up that they treated in this way for many years. Just for interest sake, one of the things I had to do when I was with Mitch Halperin in my fellowship was he made us learn by experimentation on ourselves what the ingestion of additional osmoles in the form of salt and then in the form of urea would do to urine output. So what we would do is measure out, I can't remember, it was 100 or 200 millimoles of sodium chloride on the one day, and then monitor our urine outputs for the rest of the day. And on another day, we had to measure 200 millimoles of urea out of a jar among the other chemicals on the shelf, and saw how this affected urine output. So while not as potent or as effective an osmol as sodium and chloride, urea does increase free water excretion, and that's really the basis of its role in hyponatremia.
Thank you. Okay, so we're going to wrap up, and if it's okay, I'm going to, we're happy for you guys to email any further questions that you might have to our team. I just want to thank our amazing speakers for these amazing cases that you presented and the talks that have surrounded it, and to thank the Young Nephrologists Committee of AFRAN for organizing this. It's been really useful and valuable. Thank you so much.
It's a pleasure.
The opportunity. Bye-bye.
And keep well. Thank you so much, guys.
It's a pleasure. Thanks, Zabia. Hope it was okay. Hope it was okay. Sorry that we mixed things up a bit there, but we wanted to be a bit adventurous, man, and try some new things.
No, it was so great, and there was so much positive feedback. I got like lots of messages on my group asking, saying that this has been really incredible.
Yeah, because as you know, we can't see the audience and we can't see the comments.
Yeah. So I'll send you guys some of the feedback because they really appreciated and found it really valuable. And if it's okay with you that I could share your email address if there's one or two outlying questions that we didn't have time for that they could ask. Is that okay?
No problem.
And then quite a few people, about 7 or 8, have asked if they could have a recording of the talk. And Letitia has recorded it. If I do ask her, would you feel comfortable if they could share it with the participants?
No problem.
No objections. No objections.
Okay, yeah. All good.
Okay. And at one time, there was about 122 participants.
Oh, wow, that's nice. Nice to know.
And usually there's about 17. So it was really great.
Sounds good. Okay, great. Thanks to you, Zabia, for putting it all together.
No, it's a pleasure.
Okay, keep well.
Thanks, Zabia. Bye-bye.
Bye, Sranta. Thanks, Deola.